welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
All right, now we'll have Hannah Moore, who is a PGY2 emergency medicine resident at the University of Louisville, and she will be presenting Journal Club on retrospective comparison between 0.3 milligram and 0.5 milligram dosing of IM Epi for anaphylaxis.
So the objectives of this journal club today are to review the literature regarding effectiveness of intramuscular epinephrine dosing for adult anaphylaxis, interpret the current study, and assess the applicability of the findings to emergency department practice. So anaphylaxis in and of itself is a severe, acute, life-threatening systemic allergic reaction that is characterized by the rapid onset of multi-system involvement. This typically affects the skin, mucosa, respiratory system, cardiovascular system, and potentially the GI tract as well. The World Allergy Organization, or WAO, states that anaphylaxis is highly likely when any one of the following criteria is met. So acute onset of skin or mucosal involvement, plus respiratory compromise, hypotension, or signs of end organ dysfunction, the involvement of at least two organ systems, or hypotension alone, which they defined as systolic blood pressure less than 90, or a decrease of blood pressure greater than or equal to 30% from baseline, all after the exposure to a likely or potential allergen. And just getting into some pathophysiology of anaphylaxis, this is high level, so didn't want to get too in the weeds here, but just to kind of create a few little buckets to help us make a little bit more sense. Classic mechanism of anaphylaxis is IgE mediated. So this occurs in three main phases. So you have your sensitization phase, your effector phase, and then your manifestation. So during the sensitization phase, initial exposure to an allergen stimulates the production of IgE antibodies, which then bind to receptors on mast cells and basophils. In the effector phase, you have this re-exposure to the same allergen, which triggers rapid degranulation of these cells. And then we see everything manifest in the manifestation phase. So we have release of mediators such as histamine and tryptase, and this leads to our classical systemic symptoms that we see. So this may include urticaria, angioedema, wheezing, hypotension, and potentially shock. Intramuscular epinephrine is the first-line agent for management of anaphylaxis. As we all know, it's an alpha-beta agonist. So when it stimulates alpha adrenergic receptors, it causes vasoconstriction. This can increase blood pressure, reduce airway swelling, and limit fluid leakage. It also stimulates our beta adrenergic receptors to relax bronchial smooth muscle, increase the heart rate, and increase cardiac output. Guidelines recommend that it be administered at a dose of 0.3 to 0.5 milligrams. So they kind of give a range, but don't really identify or state which end of the range is particularly preferred, unless there is a weight difference, which we'll get into later. And they do recommend that this dose be administered intramuscularly every 5 to 10 minutes as needed. Onset of epinephrine is 5 to 10 minutes, and it does have a half-life of 45 minutes. Some potential adverse effects, more so related to intramuscular epinephrine, include restlessness, tremor, palpitations, nausea, vomiting, headache. And when we think about our continuous infusion epinephrine, that's when we are really more so concerned with our cardiovascular effects. So maybe potentially tachyarrhythmias and myocardial ischemia. A lot of times I think providers tend to lean maybe towards these lower doses of epinephrine, even in the intramuscular route, because of concerns with the cardiovascular effects, but we will look into some primary literature regarding the cardiovascular effects here. So this was a study, an observational cohort study, that assessed cardiovascular events in 301 patients that presented to the ED, the allergy, or anaphylaxis and received at least one dose of epinephrine. You can see there I broke down the routes of administration. So 67.7% of patients received intramuscular injection via an autoinjector like an EpiPen. 15.6% had IM injection. 8.3% had sub-Q injection, 3.3% were IV bolus, and 1.1% were IV continuous infusion. Cardiovascular adverse events occurred in 10% of patients that received IV bolus epinephrine compared to 1.3% that received IM injection. And these were the two, so adverse events and overdose were the primary outcomes here. Overdose was observed again in 13.3% of IV bolus patients compared to 0% in intramuscular patients. These findings were both statistically significant. So this current study concluded that IV bolus epinephrine carries a much higher risk of cardiovascular adverse events and overdose compared to IM administrations. So the findings did support consideration of higher IM doses rather than higher IV or IV bolus doses, as clinicians often hesitate to increase IM dosing due to this potential cardiovascular risk. And looking here at another study, this was a retrospective chart review that evaluated patients that received 0.5 milligrams or a higher dose of intramuscular epinephrine for the treatment of anaphylaxis secondary to allergy shots at an outpatient allergy practice. So this was a small study. 38 patients received a dose of 0.5 intramuscular epinephrine, and of those, 29% required a second dose, 5% required a third dose, and 42% were transferred to an emergency department for persisting symptoms. This study concluded that there were no adverse reactions or fatalities, and that IM epinephrine at a higher dose of 0.5 milligrams is likely safe and effective for the treatment of anaphylaxis. And then here I just wanted to highlight different epinephrine dosing recommendations across 5. These are big clinical guidelines. So you can see here that the route is pretty standard. All of these guidelines recommend intramuscular injection into the thigh, and they all reference this range of 0.3 to 0.5 milligrams. There is limited data comparing the different dosing in these ranges, so it's kind of hard to say, which one may be preferred in a certain patient population. And that leads us to our literature gap. So there are limited studies evaluating the safety and efficacy of various doses of epinephrine in the setting of anaphylaxis. And this brings us to our current study titled Retrospective Comparison between 0.3 milligram and 0.5 milligram dosing of intramuscular epinephrine for anaphylaxis. And this study was published by Jackson and colleagues in October of 2025. And as far as the authors knew, and as far as I am aware, this is the first study to directly compare different doses of IM epinephrine for anaphylaxis in the acute care setting. The objective here was to investigate the incidence of escalating care after initial epinephrine dosing for the management of anaphylaxis. The trial design here, so retrospective single center, although multi-site within a single center cohort study. It was conducted at Vanderbilt University Hospital from January 1st, 2018 to November 17th of 2024. And for inclusion criteria, patients were included if they were at least 18 years of age and if they had received at least one dose of IM epinephrine for anaphylaxis. And I just wanted to highlight here that this study also used the same definition of anaphylaxis by the World Allergy Association that we talked about earlier in the slides. Patients were excluded if they received an IM epinephrine dose from emergency medical services, so prior to arrival, or if they self-administered their own epinephrine autoinjector, EpiPen, prior to arrival. They also excluded patients that were less than 50 kilograms. And for methods here, so 433 patients were screened. There were originally 304 patients in the lower dose or 0.3 milligram group. Of those, 60 were excluded, and the most common reasons for exclusion were receipt of epinephrine prior to arrival or receipt of epinephrine for another indication. And then for our higher dose or 0.5 milligram group, 33 patients were excluded there. Again, similar exclusion or reasons for exclusion compared to our lower dose group. Final methods here, so 254 patients were included in the lower dose 0.3 group, and 84 patients were included in the higher dose 0.5 milligram group. And for outcomes, so the authors had a primary composite outcome that included incidence of escalation of care for anaphylaxis after receipt of initial dose. And they defined this by any of the following within 6 hours of the initial dose: administration of an additional dose of IM epinephrine, initiation of an epinephrine infusion, or intubation secondary to progression. For secondary efficacy outcomes, resolution of symptoms after initial dose, and then length of stay in ED, And then for the safety outcomes, they looked at essentially cardiovascular adverse events here. So peak change in heart rate, systolic pressure greater than 200, ischemic changes noted on EKG, atrial or ventricular arrhythmia within 6 hours of initial dose, and then elevated troponin within 12 hours of initial dose. And for statistics here, the authors concluded that based on previous studies, they assumed a 13% baseline risk of escalation of care among patients that received 0.3 milligram IM epinephrine for the initial treatment of anaphylaxis. So due to this, they determined that a total sample size of 332 patients and a ratio of 1:3 would achieve 80% power. And like we talked about on the method slide, this sample size was achieved, so power was met. Categorical variables were analyzed using chi-squared and Fisher's exact test. Continuous variables were analyzed using Mann-Whitney U tests. Factors independently associated with the primary outcome were assessed using a multivariate logistic regression model, and then the Hosmer and Lemichaud test was utilized to assess goodness of fit regression model. And here we have some baseline characteristics. They were relatively similar between both groups, but I did want to highlight two notably that were statistically significant. So more patients in the higher dose group presented with anaphylaxis, so that was the reason for presentation rather than coming into the ED for another symptom or another event and then having some sort of allergic reaction during their stay. And then more patients in the higher dose group had facial or mouth swelling. So again, I think to me this makes sense. Maybe in our patients that we might be more concerned about potentially preventing intubation, we may use these higher doses. So just something to note there. And then I did want to highlight the receipt of additional medications. So the authors define that as concomitant steroids, concomitant antihistamines, or concomitant albuterol, although that finding was not necessarily significant. For our efficacy outcomes, so patients in the higher dose group, so the 0.5 milligram group, had significantly lower rates of escalation of care, including need for an additional dose of epinephrine and need for epinephrine infusion. Symptom resolution after the first dose was significantly higher in the higher dose group. Hospital admission rates were lower in the higher dose group, and emergency department length of stay was shorter in the higher dose group. So overall, the higher 0.5 milligram dose was associated with better clinical outcomes and reduced resource utilization. And then here we can see some of our safety outcomes. There were no major differences in safety outcomes between the two groups. However, not all patients had these labs and vitals obtained. So you can see that we used N over total in a lot of these groups. Since this was a retrospective study, not all of these patients had a troponin obtained or had EKG obtained, et cetera. So the authors were kind of just looking at those values for those patients that did receive those labs and vitals. So the study was not powered to detect a difference in safety outcomes. Again, these findings are kind of difficult to interpret due to insufficient data here. And then here we can see our multivariate logistic regression model that was conducted to determine factors independently associated with escalation of care. So after adjusting for these factors, initial dose and receipt of additional medications, like we talked about the steroids, antihistamines, and albuterol, were associated with an increased risk of requiring escalation of care. So the authors concluded that an initial intramuscular dose of epinephrine 0.3 milligrams for anaphylaxis was associated with an increased need for additional dosing, increased need for initiation of epinephrine infusion, and a greater chance of requiring intubation. So these findings continue to support the World Allergy Organization weight-based recommendations for adult patients with anaphylaxis and may even support higher initial doses to prevent that escalation of care. The authors were unable to make conclusions on the safety between the different doses due to insufficient data, although no major adverse effects were noted. And as for strengths here, so they included patients from multiple hospitals within one health system. So although we are in one health system, having those large level 1 trauma centers and those community centers all within one system can help with some of that affect our external validity. This is the first study directly comparing clinically relevant doses of epinephrine, so there has not been a head-to-head study the authors noted or that I have seen. So this is kind of the first study looking at these different doses. And then they did use the multivariate logistic regression to work through some of those confounding variables. And then they did adequately meet power, so this limits our potential type 2 error. Of course, this was retrospective in nature, so relying on charting and documentation, definitely a limitation here. And then there could be some potential selection bias. We saw that in our baseline characteristics, some differences in the different patient populations that received the higher dose to begin with. So maybe some potential selection bias there. We talked about incomplete safety data, so not all of these patients received the same orders and vitals and labs or had that data to work with, so definitely a limitation there. And it is a single health system, and there was no randomization. So key takeaways here, for adults weighing at least 50 kilograms that present with anaphylaxis, administering higher doses of IM epinephrine, so that 0.5 milligram IM epinephrine is associated with nearly 75% reduction in escalation of care, no significant increase in adverse cardiovascular events, and better symptom resolution and more efficient resource use. And that is all I have as far as slides go. I'm happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.